Right. Good morning, everybody. I'm hoping that my talk on ED attracts a bit more interest for the generalist amongst you. Again, like Paul, like VJ, there's not an awful lot new in the field of ED, but a few things that should have us at least thinking. So what I'm going to talk about are these things here. So I'm going to talk about the rise and fall of shockwave therapy. I'm going to talk about that old chestnut alprostadil. I'm going to talk about the vacuum device in 2015, surgical developments, and a bit more about the use of PDE5 inhibitors. So what about shockwave treatment? Well, 2 or 3 years ago, we all thought this was going to be the big thing. And I'll do my best not to upset VJ, who's a big advocate of shockwave therapy, but I think it's kind of come and stood still, if not gone away. For me, shockwave treatment for ED is a bit of it's the king's new clothes. I sat and looked at PubMed last night and I saw 25 citations, and all 5 of those were prospective studies. A lot of reviews, a lot of commentary, but mostly stuff about Peyronie's. Now, I know there are people out there who are still using the shockwave devices. I gave mine back. I gave mine back to the company, and I know my colleague Roland in Edinburgh, who was probably the first in the UK to have a shockwave device. Roland's numbers have started to fall off as well. So I would say to the current place of shockwave treatment is maybe a bit like collagenase is going to be in Peyronie's. It's for those who want it, and it depends how much you market it and how much you sell it. But I'm still not sure it's the answer to the man with ED. What about alprostadil? Well, I suppose as urologists, we don't really see many of the men who are injecting. That's all kind of out there in the world of primary care or with our ED nurse. We have had a few issues with alprostadil, and I suppose it's relevant to all of us in urology. The big thing has been the lack of availability of Caverject, which is the commonest branded preparation that we use of alprostadil. If any of our GP colleagues who attend BAUS were to tell you there's shortages of everything at the moment, and a lot of it I don't understand, but there's a big shortage of Caverject. And what does that mean? Well, that's meant that GPs have been on the phone, they've been on the email, patients have been on phone, patients have been on the email, coming back to be re-educated and re-dose titrated to Viridal, which is the one that does seem to still be available. So there's been a big time implication involved with this. We used to be able to go to our pharmacy and say, make me up some bimix or trimix, but for those of you who are anti-EU in these current times, the EU has kind of scuppered that. So what our pharmacists would call ex-temp or specials, unless you have an EU manufacturing licence, you cannot make yourself a bimix or a trimix or something else that you might like without one of these licences. Now, there are a handful of these units with licences in England. In Scotland, we've got 1. So unless we go to make a special order to Tayside, which is Dundee, otherwise you end up buying another product. So there have been changes. Alprostadil remains restricted on Schedule 2, despite its loss of patent protection, which means that all these branded variations, which includes Caverject, includes Viridal, includes Vitaros, includes Muse, all these things still attract a premium price because it's still on Schedule 2 restriction. What else? What are we going to talk about? The vacuum device. Well, whereas I think shockwave treatment has been the rise and fall, the vacuum's been a bit of the fall and rise. And when I was a trainee, I thought, God, thank God they brought out Viagra. I can stop all these poor guys having to use this cumbersome vacuum device. Well, the vacuum seems to have come back a bit again. Now, why is that? Well, is it better devices? Well, if you were to believe the amount of literature that I get from vacuum manufacturers that are sitting on my shelf, it must be because they're better. Is it down to better tuition? Well, certainly some of the companies now offer one-to-one tuition, whether they do that in your clinic time or whether they do that in the patient's home. It seems to make a bit of an effect. One of my trainees presented a paper at the Scottish Urological Society, and the take-home message from that was that the improved efficacy of the vacuum was solely down to the quality of the tuition that the patients received. Some of this is down to the lack of availability of Caverject. Some of it's down to the fact that new treatments that people always think are around the corner, including shockwave treatment, haven't done quite what we thought they would do. It still has a role in Peyronie's, and perhaps that's revitalised it a bit. And then the old chestnut of penile rehab has reared its head again. And without wanting to tread on the toes of Messrs Erdley and Mortorsi, who are going to talk about penile rehab later, I think the re-emergence of the vacuum has largely been on the sort of post-surgical, post-prostatectomy ED. I was reading in bed last night a paper from Guidelines by Mike Kirby et al., which is strange bedtime reading for a fellow like me, but it seems pretty much that the vacuum in penile rehab is based on a couple of fairly historic papers, one from Rayna and the Cleveland Clinic. It showed that good compliance with early vacuum use meant you were less likely to have girth or length loss. And then another paper around the same time which showed that your IIEF scores and your stretched penile length were likely to be better if you had good early use of vacuum therapy post-prostatectomy. There's a lot of interest of combination of vacuum plus injectables, vacuums plus PDE5s, vacuum plus nerve stimulators, but it's all just playing around, I think, as we stand. Surgery, well, there's not been anything new really in the last year. I suppose the things the implanters amongst us would talk about, the development of the Coloplast Titan. The little picture on the left here shows the transition of the Coloplast pump from the traditional through the OTR, or one-touch release, to the most recent, the Titan Touch with the button. Feedback from this seems fairly positive, both from implanters and from patients. And the other thing, which is more talked about by implanters across the pond, is the variations in the anatomical placement of the reservoir, avoiding the cavarexius in the post-prostatectomy and the post-cystectomy patient. Steve Wilson and Paul Perito, amongst others, have presented some fairly eloquent studies, and at the ESSM I saw Steve present some cadaveric work on balloon placement. We do a bit of this in cystectomy patients, but it's certainly not the norm or the trend, I think, in the UK. PDE5 inhibitors, well, no, not much new to say, I suppose, but it would be rude of me not to mention PDE5 inhibitors. When I did this talk 2 years ago, we were on the cusp of Pfizer losing their patent on Viagra. That, of course, has since happened. Generic sildenafil has appeared, and the per unit reduction has been up to 93% of cost, and that can never be a bad thing. In England, you've de-restricted sildenafil from the scheduled list system. We didn't do that in Scotland. That's our fingers up to full fiscal autonomy, I suppose. Cialis has its Lutz BPH licence, and the one PDE5 inhibitor that's appeared on our marketplace here is Avanafil, marketed as Spedra by Menarini. See a little bit about Avanafil. It's selling itself really as a rapid onset agent. It's got 3 pivotal phase 3 studies in general populations, in diabetics and post-prostatectomies. It's got an open label extension, and most recently they had a phase 4 study specifically looking at its biomechanics in terms of rapid onset. That's its SEP3 data for general populations, and if you do all the fancy comparative studies, it's pretty much the same as the other PDE5 inhibitors. It's yet to go in front of our SMC in Scotland. It's been accepted by a number of CCGs in England as second place to generic sildenafil, based largely on cost. What happened to the use of PDE5 inhibitors? Well, I make no apologies for using Scottish figures, because I have access to completely accurate figures for Scotland, whereas nobody would give me proper figures for England. I would assume they were lying. So this is based on financial quarter. So starting on the left-hand side, we've got quarter 1 of 13-14, which is April, May, June. So you can work out the rest from there. So this shows what the cost of sildenafil prescribing was, and you know, if you magnify this across the whole of the UK, you'll see what the trend is. So you see that the overall cost, the amount of money we spend on sildenafil has dropped, and that's largely due to the reduction in the 150 milligram Viagra preparations. Overall, it's settled down quite well. So if you're a health economist, the fact that you've saved over £1 million a year just on sildenafil cannot be a bad thing. In terms of the volume, well, it was expected in England with de-restriction that there would be a bit of an upshift in numbers. Although we've not de-restricted it, there has been still an increase in the amount of sildenafil prescribed, and that's continuing to go up ever so slightly. How does it affect the other PDE5 inhibitors? Well, Not very much. There was not very much vardenafil prescribed at all. Cialis has not really changed, although there's been a bit of a drop in the on-demand dosing dispensed, and a bit of an increase in the once daily, which is probably what Lily would expect. And the volume of ED drugs in Scotland is kind of like that. So, is there much happening in ED? Well, not a lot that's new. The best thing is that people still continue to realise that ED is part of the men's health spectrum, and it's not just a lifestyle. I don't think there's any major treatment innovations. There are some old friends making a return, and the big thing when I go and talk to GPs is they're still squabbling about who pays for it. So thank you very much.
Thanks, Mike. Any questions from the floor? So in Scotland, can you use Cialis 5 milligrams once a day for ED inlets?
Yeah.
You can, free of charge to the patients? No.
Can't use anything free of charge in Scotland.
You're not?
No.
Okay.
Unless it's tagged on to something else. No, I don't think so.
Okay.